I let her know that I can only be on the call for about
Good morning, everyone. My name is Kathy Bernard, President and founder of the Save Your Skin Foundation. It is with pleasure that I welcome you to the 5th annual Patients Redefining the Future of Healthcare in Canada Summit on behalf of the organizers, Save Your Skin Foundation, the Canadian Psoriasis Network, and Sharon Clark, Associate Director, Office of Indigenous Initiatives, and Office of the Provost and Vice Principal Academic at Queen's University. Also, thanks to the Conference Board of Canada for joining us to organize the Value-Based Healthcare panel. I would like to begin by acknowledging the Indigenous peoples of all the lands that each of us is on today. While we meet on a virtual platform from coast to coast to coast, we acknowledge the ancestral and unceded territories of all the First Nations, Inuit and Métis peoples that call these lands home. We affirm our commitment and responsibility to improving our own understanding of our local Indigenous peoples, including First Nations, Inuit and Métis, and to improving relationships. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past that continue, and to consider how we can each, in our own ways, move forward with meaningful efforts of reconciliation. I would also like us to remember those who have lost their lives over this past devastating year, whether or not directly or indirectly from this pandemic. We will miss them all. I send well wishes to those who are ill and wish them a speedy recovery. I heartily and sincerely thank first responders and all other healthcare workers who have and still are working long, difficult hours on our behalf across this country and in other countries around the world. Never have the issues of the sustainability and effectiveness of healthcare systems and delivery models been more in the forefront of people's minds than they are today. Never have patients felt more that they need and are entitled to a meaningful voice in the future of these systems upon which their welfare, in fact, everyone's welfare, so profoundly depends. Let's be clear, serious problems with the healthcare systems have existed long before this pandemic. Those of us engaged with that system on a regular basis have known it and have been sounding the alarm bell for a long time. The pandemic has exacerbated these problems and has probably created some new ones. Sadly, now the general public knows this terrible reality. This summit has always recognized the need for real change led by patients who know in real world terms what we need. In previous years at this summit, we have worked together to determine how this real change should be achieved by and for the benefits of patients and their supporters, and actual for all populations across this vast country. We have concluded that only a value-based system tailored to Canada and resting on a strong foundation of outcomes that matter to patients, enabled by relevant evidence from consistent, connected, and confidential data, and managed through integrated models of care focused on serving specific populations, will ensure that everyone across our country receives the healthcare and health outcomes that they need and deserve. Our collective experience during this pandemic is an important overlay to this pre-existing underlying problems. It requires us all to look ahead with additional information. What will virtual care mean when widely implemented? How do we ensure that health systems provide needed access and positive outcomes for all people across Canada? How do we ensure that those who have often been left out of proper planning and implementation of our health systems are included? How do we ensure that Indigenous peoples lead and have their own distinct voices heard in a meaningful way for their healthcare solutions? These are questions of utmost importance for patients and people in general at this time. Over the course of the summit, we will explore these questions with a host of experienced, keynote speakers and panelists. We will take in their wisdom, and as in every year, we will develop and amend existing action plans. I would argue that by the end, we may well conclude that our healthcare and delivery systems, like an old house, cannot be renovated, but must be rebuilt from its foundation. We could not host this event without the support of our sponsors, all of whom provided unconditional funding and other resources to let patients plan, develop, and implement this summit entirely independently. In alphabetical order, thank you to Amgen, AstraZeneca, Bristol-Myers Squibb, GlaxoSmithKline, Janssen, Leo, Merck, and Novartis. Thank you to Innovative Medicines for the support of our 2020 working groups. Thank you to the Conference Board of Canada for sponsoring the value-based healthcare panel on December 8th. Thank you to Rena Rupa Aurelia for the breaks. And thank you to our breakout group facilitators, Ron Roseness, Cheryl Ann Simoneau, Eva Villalba, Leah Stevenson, Madge Ganbin, Christina Sitt, Martina Elias, Sharon Clark, Monica Slovenik de Angelo, Joanne Harabas, Stephanie Michaud, Nicolas Moraz, Isabella Moraz, and Lori Cameron. Thank you to our wonderful working groups, Eva Villalba, Chanel Pathak, Johanka McPhee, Jennifer Graham, Margaret Peters, and the members of each of our 3 active working groups this year, integrated models of care, data, and patient-reported outcome measures. Thank you to Red Tree Productions for the AV support. Thank you to Leah Stevenson for strong backbone support for the activities of the working groups and Summit Steering Committee, and the amazing facilitation I know she will do. Very special thanks to Chantal Burles for logistics and administrative support, as well as Natalie Richardson, Ms. Bono, and Marianne Guignot, the amazing Save Your Skin team. And last but definitely not least, thanks to our hardworking and stalwart steering committee members, Antonella Scally, the Executive Director of the Canadian Psoriasis Network, Louise Binder, the Health Policy Consultant at Save Your Skin Foundation, and our newest permanent member and contributor, Sharon Clark, Associate Director, Office of Indigenous Initiatives, and Office of the Provost and Vice Principal Academic at Queen's University. Also thanks to Monica Slovenik D'Angelo, Director Health at Conference Board of Canada, for joining us to organize the value-based healthcare panel. And most of all, thank you to all of you for joining us. have a stimulating and inspiring summit experience. Over to you, Leah.
Thank you, Kathy, for that warm welcome. Welcome once again, everyone, to our 5th annual Patients Redefining the Future of Healthcare in Canada Summit. This is our first one that is virtual, so hopefully everything goes super smoothly. My name is Leah Stevenson. As I was kindly introduced, I am a healthcare and systems change consultant who is motivated by my lived experiences as a caregiver and as a daughter. And I am very honored to be the event's overall facilitator for the upcoming 4 days. So just briefly on what's going to be happening over our upcoming 4 days, on behalf of everyone who has worked so very hard to bring this event to you, we're really pleased to be able to offer you 4 sessions spread out over, as I mentioned, 4 days. We wanted to try not to tire you out, so we hope that you will be able to make all of our sessions. They do aim to build one upon the next. However, we know how busy everyone is, so we will be recording each day and posting the recordings here in the portal as soon as possible after it ends. So if you miss something, hopefully you can catch up on it. Today, we are excited to start with our keynote speakers who will help us remember what the world was like in health and healthcare in Canada before COVID-19 arrived. As Louise likes to say, help us take off our rose-colored glasses. They will outline some of the major impacts that COVID has had on people across Canada. And finally, they will share their vision of the future and recommendations for what we should be looking towards in the future. On December 3rd, this Thursday, we will have panelists dive into these similar questions, but they will be focusing on particular populations who, as many of you know, both before COVID and now even more so with the pandemic, face barriers to health and to healthcare. And namely, we'll be focusing on older adults, people living with income insecurity, and people living with mental health conditions. And we have tried hard to ensure that Indigenous perspectives are being woven throughout these panels. On December 8th, we're going to turn our focus towards solutions. As some of you know, our past summits have been building understanding and consensus on value-based healthcare as a solution for Canada's healthcare issues. Last year, 3 working groups were formed, focusing on integrated models of care, patient-reported outcome measures, and data. And you will hear what they have achieved over the last year. In addition, we're excited to have a panel of stakeholders from government, data governance, and integrated models of care who will comment on the opportunities that they see to grow these elements of value-based healthcare in Canada. Our last day, December 10th, is open to our patient, caregiver, and patient group participants, as well as citizen groups who've joined us. As usual, we will be reporting back on the themes that come out of these first 3 sessions and developing working groups together to continue our efforts on key issues and opportunities together in 2021. I encourage everyone to take notes during the presentations and panels, take note of things that you consider to be important issues, really exciting opportunities or key messages that are really resonating for you, as you will have an opportunity at multiple points to ask questions or to share your thoughts with each other. Each day we are going to have moderated question and answer session. So that's your opportunity to enter your questions at any point during the presentation into the Q&A box. And the moderator will aim to have as many of the questions that you have entered answered as possible. Each day will also end with breakout sessions. So we're going to have patients, caregivers, and patient groups in breakout sessions together. Industry will be in a group, and all of our other healthcare stakeholders will be in a group together. We're aiming, as always, to create safe spaces for people to freely share their ideas with each other. And finally, we're excited to offer mindfulness meditation today during our break, and on December 8th as well. On December 3rd, we're going to share a couple of really inspiring videos that highlight a couple of integrated models of care that are doing some fantastic work serving some of the key populations that we are discussing on December 3rd. Now, a little bit of housekeeping. If you have a technical issue at any point during the summit, please do click on the help link and you'll chat with our event producers who will help you solve your tech issue. As I mentioned, we'll be having a question and answer session on each day, including today. And I strongly encourage you to enter your questions as they occur to you by clicking on the Q&A button, which many of you will see at the bottom of your screen. The Q&A moderator will keep an eye on them and will convey the questions to the presenters once we reach that part of the agenda. For the breakout sessions, you can find out which breakout room you're in by going to the lobby, where there is a table with all of the details. If you do not see your name on the list, as we do have open registration still, so we may have missed you. And if you identify as a patient or a caregiver or a patient representative or a citizen representative, please go to breakout room number 11. If you identify as industry and you don't see your name on the list, go to breakout room number 9. And if you're from another stakeholder group and you're not on the list, go to breakout room number 10. And when the time comes, it will be easy to find your breakout room. You just need to click on the sessions link, scroll down the list of sessions, and you're going to see numbered breakout rooms. Breakout room number 1, number 2, number 3, and you just click on the room that is assigned to you. Again, if you have any tech issues at any point, just click on help and someone's there to help you. And I also encourage everyone to please complete our evaluation surveys. They will be sent out after each day, plus there will be one final evaluation after the event is over. Your feedback is so important and helps us improve a lot, especially since this is our first virtual event. We could really use your feedback. We will be sending out a post-event report in English and French after the event. And now I am pleased to introduce my dear friend and longtime colleague, Louise Binder. Louise is a lawyer and health advocate who has been involved in informing the development of health policy and systemic treatment access practices from the patient perspective since the early 1990s, subsequent to her own HIV diagnosis. Louise co-founded the Canadian Treatment Action Council in 1996. She began similar work in the cancer area and is presently the health policy consultant with Save Your Skin Foundation. She's been recognized by many organizations for her outstanding work, including receiving an honorary doctorate of laws from her alma mater, Queen's Law School, the Order of Ontario from the province of Ontario, and 2 Queen Elizabeth II medals. Welcome, Louise.
Good morning, good afternoon, and good evening, depending on where you may be joining us. I want to warmly and most sincerely echo Kathy's words of welcome to all of you to the 5th annual Patients Redefining the Future of Healthcare in Canada Summit. As you would expect, I'm sure, my warmest welcome goes to the patients and their supporters joining us today. This is the first summit, as Leah mentioned, that is being held virtually for the tragic reasons of which we are all far too well aware. In the midst of these terrible times, we have never needed to come together more to share our strategies and tactics for foundational restructuring of healthcare in this country. This pandemic is a clarion call for change in so many ways. Patients, patient groups, and our supporters, diverse in so many ways, and from far-flung regions of our vast country, are answering that call, as we have done in earlier times of crisis. In fact, we have been there throughout. Even when things appeared on the surface to the public to be smooth sailing, we have known better and have spoken out. And we have never in our lifetimes been thirstier for wisdom, experience, and steady hands at the helm. Today, it is with great honor and humility that I introduce our keynote speakers, who epitomize these qualities, as you will soon hear. First, I am privileged to introduce Carol Hopkins. Najem, meaning Mother Wolf, is of the Wolf clan from the Delaware First Nation of Moraviantown, Ontario. She is the mother of 4 and grandmother of 6, which I can hardly believe. Carol is the executive director of the National Native Addictions Partnership Foundation, an organization that supports Canada's First Nations addictions programs. Before this, Carol worked at the Nimki Nipikawangan Health Healing Center, a youth solvent abuse treatment center founded on Indigenous culture and lifeways, where she served as the founding director for 13 years. Carol was the co-chair, First Nations Addictions Advisory Panel, developing a renewal framework for the National Native Alcohol and Drug Abuse and the Youth Solvent Abuse programs. Carol now co-chairs its leadership team, mandated to implement the renewal framework. This process is a partnership between the Assembly of First Nations, National Native Addictions Partnership Foundation, and First Nations and Inuit Health Branch of Health Canada. Carol's work in the field of addictions also included serving as the chairperson of the National Youth Solvent Addiction Committee from 2000 to 2007. This national committee has maintained a partnership with many groups to develop best practice guidelines for culturally based inhalant abuse treatment. Carol has represented First Nations clients on the board of directors of the Canadian Council for Health Services Accreditation, now known as Accreditation Canada, and in this role, she was involved in the development of the accreditation program and standards. She was also a surveyor for this group in both the mainstream healthcare system within Canada and First Nations community health and addiction organizations. Her ability to blend Western and Native traditional health and healing practices is outstanding. Carol has taught in numerous post-secondary institutes, including Anishinaabe Education Institute, the Native Social Work Program at Laurentian University, and currently as a professor in the Social Work Program at King's University College of the University of Western Ontario. She holds a Master's of Social Work degree from the University of Toronto. In recognition of the outstanding work that she has done, in the field of social work and First Nations, Carol has received the well-deserved Walter Dieter Award from the Assembly of First Nations. In 2017, she also received the Order of Canada. Carol has made numerous presentations nationally and internationally to Indigenous audiences, government, healthcare professionals, and to academic audiences. And now we have the great good fortune to have her present to us. And I turn the floor over to the amazing Carol Hopkins.
Waiwana bojo, no jem indishna cause gaye maing gana dodem, lani lanape kwe and dao, medewana kwe and dao. I'm joining you today from the Delaware Nation at Moraviantown in southwestern Ontario, and I'm honored to have received this invitation to share some words with you today. I'm going to be talking about First Nations in terms of redefining healthcare, and I have one key message, and it's about our worldview. And I'm just trying to see how to make these slides go forward. Always a challenge when you can't find your mouse. Here we are. Okay. So I want to start off by sharing with you that our stories of creation, First Nations people have many cultures across this land. And our culture is defined by our language, our connection to land, and our knowledge of our stories of creation. And this goes back to before there was anything physical in this world. That's where the stories of creation begin. And one central truth across all of the different cultures is that the Creator thought of everything that we would need in creation forever and all time. And so what that means to us is that no matter what we face, that there's always an answer, and that we have to seek out what that answer is. And there's many patterns that continue to repeat across time. And we talk about those patterns as our evidence base. We can continue to rely on those patterns to inform the way we think, such as the moon is a great teacher about patterns, a great teacher about change, because she follows the same consistent pattern in the sky every single night across the months. She continues to show her presence and is a great teacher about change. And so we're in that time of change where First Nations people are sounding their voices about how they experience healthcare. Unfortunately, more recently, those stories are the stories about pain and suffering of the systemic racism that First Nations people have seen. They're tragic stories. That's why I say unfortunately. But fortunately, those voices are being heard. We know in the healthcare systems that there are various avenues to lodge complaints, to speak to the substandard care, but not often are those voices heard or responded to. And so one of the things that is critically important for First Nations is that our values, our way of being is informed by our understanding of who we are as a people in this country. And so that's why I'm starting off with this presentation about our worldview. We also know that what was given to us by the Creator, and it's embedded in our stories of creation, is our language. Every being in creation was given a language, and that language is our medicine. So just like all of the animals, all of the winds, all of the trees, they have their own sound. We as people of this land were given our own sound. And so across the country, there are many First Nations languages that inform their way of thinking and their way of being. And a constant and continuous foundation that ties us all together in the same understanding is that our language is the key to our medicine. And so on the slide in front of you, I have a picture of a drum. The drum is what connects us to our heartbeat, and that ignites a connection to our spirit and a connection to the Creator, the Great Spirit. And the way we connect is through that sound, but it's also through our language. That's a huge concept to try and understand. But when you think about receiving healthcare, in some regions of Canada, First Nations people, Inuit people, or Métis people, all they speak, their first language, is their original sound, is their original language. And then when they enter the healthcare system, they're not always able to receive healthcare in their language, in their first language. And so there's a translation. That translation requires the support of family members or people from their culture that can help ensure make certain that what is being communicated across the healthcare system specific to their needs is understood. So language is a critical medicine. And our knowledge systems as Indigenous people, we have a way of knowing. And so our stories of creation are not of the past, something that happened a long time ago, or a myth that is told to entertain our children. Our stories of creation are the foundation of all of our knowledge systems, including our understanding of medicine, including the understanding of the physiology of the human being. And so our knowledge systems are still intact. They have not ever gone away completely, even through colonization. While they were silent, they never went away completely. And so we still can draw on them to inform our way of being and our way of practicing medicine. We're in this time now, and I'm so thankful for this invitation to be speaking to you today, because we have to embrace, if we are going to create change, we have to embrace and participate collectively in the decolonization of Indigenous knowledge. The epistemic racism, which is the judgment and valuing of which knowledge is more credible. And unfortunately, in our history, Indigenous knowledge has been silenced because our language was silenced through legislation that we know as the Indian Act, through the residential school system. And so as that language was silent, our knowledge became silent. It didn't go away, didn't disappear, but it was silenced. And so that led to the colonization of our knowledge, the belief that it's just fictitious stories, and that is not the truth. Our knowledge base also has a strong foundation of evidence. So we have to think about what is decolonization of knowledge and how do we include Indigenous knowledge as evidence. It takes, everybody is talking about cultural competency, cultural humility, and cultural safety. And that is a conversation that challenges us to question, to be aware of, to learn about our own values, our own education processes that led us on our journey of the professions that we have chosen, so that we can begin to find space for understanding what might be ambiguous, might not be well understood. And we can create a pathway to our future that is appreciative of differences, appreciative of similarities, and that we can learn to straddle that road in a way that supports differences. We're a country in Canada with many different nations of people, with many different ways of understanding. And I'm going to share with you now an example of that knowledge and that evidence. And so our story of creation, it starts talking about the star galaxy. And again, based on those patterns of evidence that is within our knowledge base. When we talk about the star galaxy, talks also about the imprint of our languages, the imprint of our knowledge. And it talks about the imprint within us as human beings of what was created by the Great Spirit. And so we understand that what we see in the star galaxy is also the same imprint within us. So in this slide, I'm talking specifically about the neuron cells. So there's language that helps us to validate our knowledge and understanding. And so this word that is in Ojibwe is monodominus, is spirit seeds. That's the translation, loose translation in English is spirit seeds. And when we look at the history of that concept, because it's not just a word, it's a full concept. And so what does spirit seeds mean? It goes back to an understanding of our genetic makeup, our DNA. And it has a physical property as well as a spiritual property. And that spiritual property is all about our identity. It gives purpose to where we come from, our connection to the land. And so it builds an understanding, a foundation for understanding that we do not exist just individually. In the healthcare system in COVID-19, we have to be very careful about the traffic through healthcare systems to protect the healthcare workforce, but also the people who are seeking healing and treatment and care for the healthcare needs. But because of the systemic racism as one issue, but also because of the values that we have in connection. There are many stories about how healthcare systems have adapted over time to ensure that First Nations people continue to have connection to family, continue to have connection to land. So just as an example, an older man in a remote region of Canada was in his latter stages of life, and he wanted to be connected to the land, but he was connected to all kinds of machines to support his life. And so his family was able to talk about those values, talk about how critically important it was for him to be connected to the land. And they set up a miner's tent outside of the hospital, was able to move some of the machinery that he needed, and he was able to receive the healthcare he needed, as well as access to his culture and what was meaningful to him in that tent outside of the hospital on hospital property. There are other healthcare settings that have a sweat lodge on the hospital or the acute care property. In this example, applying that understanding about monodominus, the spirit seeds, I want to tell you a story about my grandson. When he was coming into this world, he was in a big rush. And so he was born way too early. He had to spend time in the hospital for a couple of months until he was ready to come home. But when he came home, what was really important was to connect him to the land. And so in this picture, what you see is his mother holding him as a brand new infant, and he was lowered and connected to the earth. What's not in this picture are all of the family that are around him, celebrating his arrival and his connection to the earth, so that he always knows where he comes from and that he can be continued to be nurtured by the environment around him. And the way we dress our children is also reflective of that. So he's in his Tikanagan, and on the side of his Tikanagan is his clan family. Our clans are our connection to the earth, critically important for our health and wellness, mentally, emotionally, physically, and spiritually. And then the way that we dress up our children is the same as dressing up those spirit seeds of life. And so in the healthcare system, how do we help dress up the seeds of life? We oftentimes are only focused on the sickness and the what's wrong with you. And we need to be also concerned more holistically about the total environment and the connection that people have that support their wellness, their health. And so we have many stories that have been passed on from generation to generation about how we ensure life. You know, thank goodness he was in my daughter and was able to get to a good hospital where she was provided excellent care while she was struggling with the birth of her firstborn. But while they were in the hospital, we were out on the land performing those ceremonies that we needed to do to ensure that he would arrive into this world safely. And so why am I telling you all of this? Because we require many partners and many alliances, and we can put our hands together to hold that light that is life. And we can ensure that First Nations people, Inuit people, Métis people are appreciated, that they're understood, that all of Canada understands that we have a right to health. We have a right to safe health care. We have a right to be treated with dignity and respect. And the more we share that story, not in a challenging way, but as a matter of human being, that we are human beings supporting other human beings, that we think about the Indigenous people of this land and we recognize their importance, their critical importance to the fabric of society, that comes from the land. We can put our hands together and learn how to work together in that way. So like the birds in our story of creation, the birds are the ones that carry the seeds of life. And they spread that everywhere. And everywhere life grows because of their work. And so I invite you to carry these seeds, whatever it is that stood out for you. One piece, maybe. What does that mean? Continue thinking about it. Share it with others. Spread the seeds. And just like the eagles, they don't typically flock together, but they do at certain times. And we recognize the eagles as the chiefs, the leaders. They're the birds that can fly the highest. So whenever you see the birds in the atmosphere in the sky, you look at them and they can only go so far, and then they come back and they fly around. But the eagle is the one that can fly the highest, and it can fly to its completely out of sight. And those are our teachers about leadership. And so invite all of you to carry these seeds, but invite you also to discover your own leadership. Don't be shy to learn about and to stand up and voice your support for Indigenous people in Canada. And when we do that, when we start having that conversation in very respectful ways, then we start to see the space that relates. And so this concept of the space that relates is also linked to our stories of creation, that the Creator, the Great Spirit, gave to every being their own road in life. And when we know about what's on our own road, then we have more space to have respect for what is on the other's road, our road in life. And it sheds light and helps us to understand and appreciate others. So I invite you to carry those seeds, to carry the alliance with Indigenous people in Canada to create a good future. Miigwech.
Carol, I took a moment to come back on because as people are not used to, I sort of have tears in my eyes. People are not used to seeing me with tears in my eyes, but I do. I know we'll have a lot of conversation in the Q&A about your comments about carrying these seeds. But I just have to tell you that I wrote your words. Each of us has a right to safe healthcare. It's a right. And we're human beings, all of us human beings, supporting other human beings. And I have to say that there's never been a time when that has been truer for me in my lifetime than during this period. And thank you for reminding us of that. We can't hear it enough. And of course, those of you who know me know that hearing the call to discovering your own leadership is sort of just true to my heart. It's true to my heart. So thank you for reminding us, and we'll have more conversations for sure after our next keynote speaker. It's amazing. And now for our next amazing keynote speaker. This is a person that I've been hoping to meet for a very long time, Dr. Kwame Mackenzie, the Chief Executive Officer of the Wellesley Institute. And I'm hoping that after this presentation, he'll allow me to call him Kwame, and I won't have to call him Dr. Mackenzie. I hope we're going to become friends. Dr. Mackenzie is an international expert on the social causes of illness, suicide, and the development of effective, equitable health systems. He's a professor of psychiatry at the University of Toronto and director of health equity at the Center of Addiction and Mental Health. He sits on the National Advisory Council on Poverty. He's a policy advisor, clinician, and academic with over 200 papers and 5 books to his name. He works across a broad spectrum to improve population health and health services. He sits on the board of United Way, the Ontario Hospital Association, and Community Food Centres of Canada. A Southampton University Medical School graduate, Dr. Mackenzie trained as a specialist at the Maudsley Hospital Institute of Psychiatry, King's College London, and Harvard University. His early clinical and academic work focused on developing community-informed, innovative strategies to increase access and quality of services. This led to advisory roles to the United Kingdom government and election to the executive of the Royal College of Psychiatrists, United Kingdom. His more recent work has investigated the social determinants of health and how they can be used to decrease illness and improve well-being. In addition to his academic, policy, and clinical work, Dr. Mackenzie is a past BBC radio presenter and columnist for The Guardian, Times Online, and more recently, the Toronto Star. Dr. Mackenzie holds an African Canadian Achievement Award for Science, Harry Jerome Trailblazer Award, the Dominican of Distinction Award, is a former Harkness Fellow in Health Policy, and a Fellow of the Royal College of Psychiatrists, UK. I heard the esteemed Dr. Mackenzie for the first time when he was being interviewed some time ago on CBC Television News about the work that he was doing regarding social determinants of health. And of course, it was music to my tired ears. I determined then and there that someday I would have the honor to hear him speak. Little did I know that I would also have the great honor to introduce that speech. Without further ado, I turn the floor over to Dr. Mackenzie.
Wow. Okay. Well, thank you. My name is Kwam Mackenzie, and Louise, thanks very much for introducing me. I'm going to allow you right away to call me Kwam, and I'll call you Louise. I'm amazed to be following, always amazed and always daunted to be following Carol, a great talk, as always, Carol, and a very, very, very tough act to follow. Now, I'm going to try and share my screen, and I'm going to hope that it all works perfectly, and I think we're okay. So, I've been in Canada for 14 years now, 14 years in Canada, but some of the things from the UK have stuck with me. Each morning when I woke up in the UK, I'd listen to the radio. BBC Radio 4 had a morning show which was called Today, and I used to listen to that. It was usually highbrow political news, but they had a lighter side. And one thing I remember making me laugh was an interview that they had of a woman who'd just turned 100. They asked her about her life, and then they ended with a question. And it's a question that everybody would ask sort of somebody who'd reached 100. They say, well, very few people make it to 100 years old. Tell us your secret. Why do you think you live to 100? And I remember there was a pause. And then the woman said to the presenter, well, I think it was my decision to get off the Titanic. At the age of 18, she'd bought a ticket for the Titanic's maiden voyage. She'd got on a boat in Southampton, looked down at the quayside, and started feeling homesick. So she got off before it sailed and waved goodbye to other people. We all know what came next. On this journey between Southampton and the UK, Southampton in the UK and New York, the Titanic hit an iceberg early in the morning. 1,500 of the 2,224 people on board died. But actually, your risk of dying depended on your age, your gender, and the type of ticket you bought. Over 90% of women and children in first class survived, but only about 35% of children and 45% of women in third class survived. 1 in 3 men in third class survived, but only 1 in 3 men in first class survived, but only 1 in 8 men in third class survived. In fact, men in third class were less likely to survive than crew. Now, the Titanic had a one-size-fits-all strategy for a disaster if they'd hit an iceberg. Get to those lifeboats as quickly as possible. But people who were in third class were in lower internal cabins. They actually needed more help to get to those lifeboats, and that help was not available. It was not part of the plan. The lack of help and that idea of women and children first explains why some people died and the others didn't. But underlying all of this, many more people would have lived if they had an equitable strategy that gave people in third class more help. They would have saved many more lives if they'd done that. And not only that, the Titanic would not have been one of the biggest maritime disasters ever. We should have learned, but we actually haven't learned that simple lesson in our health service. We have a Titanic strategy. We should know better. And that's for our health service and for COVID-19. Now, we went into COVID-19 knowing 3 things. First, we knew that 85% of our risk of any illness is social. The Canadian Medical Association have shown that. 50% is because of factors like income, your life, and employment, and racism. 10% is because of your environment, and 25% is your access to good quality healthcare. So the first thing we knew, 85% of our risk of any illness is social. The second thing we knew is that in Canada, these risks are not just theoretical, they're real. In the Code Red study in Hamilton, there was a 25-year difference in life expectancy between rich and poor. Indigenous people in Canada have much shorter life expectancies. Immigrant and refugee and racialized groups in Canada are more likely to get ill. And those same factors that make you sick are also linked to decreasing your access to healthcare and to poorer healthcare outcomes. In Canada, we too often see something called the inverse care law. People who are less sick but have access to knowledge, power, and connections get more care than those people who are more sick but don't know how to play the system. So we knew 2 things. We knew, first, there were health disparities linked to the social determinants of health. And second, health services were not decreasing those disparities. But then we knew something else. There should have been alarm bells at that time. We should have known that there would be problems in pandemics because actually we had the data. We actually knew that the risk of influenza was different in racialized groups during H1N1. Actually, data in Ontario showed that Southeast Asian people were 3 times more likely to get infected with influenza during the influenza pandemic, the last one, that South Asian people were 6 times more likely to be infected, and that the Black population was 10 times more likely to be infected. So we knew 3 things: social determinants of health, health services not making things better, and that people who had increased risks of health problems and racialized populations were more likely to be infected during pandemics. So we knew all of that, but despite that, we went into COVID-19 with a one-size-fits-all pandemic strategy, a Titanic response, which would predictably not work as well for some people as others. And that Titanic strategy impacted with the social determinants of health to change your risk of illness. There are 4 ways that COVID-19 pandemic impacts health. There's the illness itself that has impacts, and that is more likely for some groups than others. There's the impact of the public health response. Actually, social distancing, physical distancing has health impacts, increased rates of domestic violence, increased rates of substance misuse, increased rates of anxiety, and those also interact with the social determinants of health. Then there are the impacts of decreased availability of medical care. The same people who have increased rates of illness are less likely to get care. And they're the same people who are going to have negative outcomes because of the economic impacts of COVID-19. So we should have known better. We should have thought it through. We should have had a better response. We shouldn't have had a Titanic response. And as the data started coming in, we started seeing our mistake. Because in May this year, the US started reporting that African Americans and the UK reported that Black Brits had at least twice the rate of COVID-19 infection, twice the rate of hospitalization, and twice the rate of deaths. Not long after that, George Floyd was killed, and the 2 together were a catalyst for community-led push for socio-demographic data collection to understand what was going on here. Communities developed strategies for data collection, but also wanted the data use. The aim was to make sure we had data so we could see whether there were disparities in COVID in Canada, and to ensure that data was used to decrease those disparities. In response to this community-led push, local public health units in Ontario and some provinces, first of all Manitoba and then Ontario, started to collect data. And we found that things were a little bit worse here than in America. This Public Health Ontario data shows the risk of COVID-19 for different populations. It shows that the Arab and Middle Eastern, the Black, and the Latin American populations have sky-high rates compared to the white population, 6 to 9 times increased rates of infections found in those groups. What this graph doesn't show you is that racialized groups get COVID younger, and they have worse health impacts as well, a greater risk of death and greater social impacts. This is from data that was collected by Statistics Canada, and it shows 3 different things about the mental health impacts of COVID. it compares the blue, which is the white population, with the grey, which is racialized populations. And it compares them on poor and self-rated mental health, whether their mental health has got worse or not, and then lastly, a measure of generalized anxiety. And what they have shown here is that the racialized populations have worse mental health during COVID. Their mental health hasn't necessarily changed as much during the lockdown, but they have higher rates of generalized anxiety. So it's troubling. Once we get the data, we found huge inequities. And of course, what's happened is the existing inequities have been exacerbated by COVID. But there's been a response. Toronto analysed the data and started to implement changes in their pandemic response. And the Public Health Agency of Canada have come out with this model, their pandemic equity model, to try and get people to produce better pandemic responses. They say we should be working with communities to develop new public health interventions that will give better support to marginalised populations. But they also say we need better housing, we need better employment conditions, we need better health and social care, because they understand that COVID has exacerbated existing problems. So there's been some success, but there needs to be more done. And there are 4 groups of things that I think we should do. We live in a country that says diversity is its strength. So we have to protect that diversity. In my mind, it shouldn't be legal to have inequitable health and social policy. Health planners should have to decrease inequities by law. They should not be able to set up health services they know will disadvantage some people. I think we need equity-based pandemic strategies. How can it be legal to set up a pandemic strategy that we know won't work for all? Why shouldn't it be mandatory for people to have equity written into their pandemic strategies, like the Public Health Agency of Canada is suggesting? But we should realise that all of these inequities happen because of social factors. And we should, when we're building back, we should build back better. Those who have been hit hardest by the pandemic should get the most support. We should be building a new normal that is better than the old normal. So we need to decrease the impacts of the social determinants of health so that we don't have as many health disparities. The disparities that we are seeing in the pandemic are because of the disparities we had before the pandemic. But last, we need the ammunition. We need data to ensure that we can identify who is and monitor inequities. We should be able to ensure we can identify where those inequities are and monitor those inequities. In democracies, if you're not counted, you don't count. And if you don't count health inequities, they become invisible. So in conclusion, the pandemic, what a pandemic tells us is that the old-fashioned one-size-fits-all strategies that produce health disparities make us more vulnerable to pandemics. And that same thinking, which ignores health equity and ignores the social determinants of health, makes low-income, racialized, and older populations more at risk during the pandemic. See, health equity is about making sure we get help to the people who need it. It's about fairness. In my mind, it's about getting off the Titanic. Thank you.
Thank you so much. I hope my other presenters can now be seen because we're going to have a panel discussion. Feel free. Nice to see you, Carol. Join us, please. I also had to take a moment after your presentation, Kwame, not to cry, but to sort of do a happy dance for a moment because, you know, words like fairness and decreasing inequities by law, and if you're not counted, you don't count, are just so inherently, to us, maybe obvious, and somehow they just don't seem to have made it through the public discourse. And thank you so much to both of you for providing, you know, awareness, education, and advice from wisdom, experience, and most importantly to me, voices of those who matter most and are often heard least. Patients and their caregivers, representatives and supporters from all populations, from sea to sea to sea. And now I'm going to turn to the audience for questions. And I think we have one question already. It's a question for you, Carol, but I'm sure there will be questions coming in for Kwame as well, and for both of you. And Kwame, please feel free to answer all questions wherever they're directed. So Carol, the question that's directed to you is, we know that mental health, wellness issues and addictions, including tragic unnecessary deaths, are rising during this pandemic, and disproportionately so in Indigenous populations. What should we be doing as stakeholders to turn this around? And what should we be demanding from governments and other decision makers? And indeed, Kwame, you know, please jump in on the non-Indigenous part of this question too.
Well, we know for sure amongst First Nations people that they are disproportionately represented in the deaths from overdose, criminalization for their drug use, rather than being supported in their right to access healthcare. So 3 key words: making sure that the services needed by First Nations, Inuit, and Métis populations who might be using drugs are available to them where they need them. And so as a background to that, there was a time when the only drug replacement therapy available to First Nations and Inuit Métis was methadone. Methadone was widely used at the time. That was the evidence. But in order to get access to methadone, they had to fly out and leave their communities permanently. And if they lived in a rural environment, they most often had to hitchhike hundreds of miles on a daily basis to access methadone. So methadone was available, but getting access to it didn't support long-term retention and treatment. And so now we've moved beyond methadone to things like Suboxone, for example. And Suboxone has had great success when implemented within a First Nations community under a community development approach. And so if you're a healthcare practitioner who has the rights to prescribe Suboxone, and if that's all that is happening, that is not the answer. There's no silver bullet. And so access and availability in the context of a First Nations environment and culture is critically important. And then there are folks that, as we know in this country, that are using drugs by injection, and that has a whole other set of complications. But again, what is the availability of the treatment, if treatment is desired? What is available for people who use drugs that do not want treatment, but want to stay alive? They're not looking for Suboxone or methadone or a drug replacement therapy. They simply just want to stay alive. They want access to drugs without being contaminated that will could take their life. Those are all of the or some of the conditions surrounding drug use, and the pandemic or the public health crisis that has taken more lives because of contaminated drug use, lack of available service, lack of access to services. And so in remote isolated communities, where they have been fortunate enough to partner with the local health authority, that's the other systemic issue, is not every health authority across this country has a good partnership with the First Nations community who has been there for many, many, many years. And I asked the question, how come you don't know who to call? It's not like the First Nation just popped up yesterday, but we're just getting to that place of building those partnerships. So again, the partnerships between the healthcare provider, healthcare authority, and First Nations communities is critically important. The federal government delegates responsibility for mental health to provinces and territories. That means provinces and territories have a responsibility to serve First Nations people no matter where they live, including in a First Nation reserve community. And so how do we make sure that those populations have access to available services where it matters in the context that makes sense to them? So those partnerships have been facilitating rapid access to addictions medicine, and but also partnering, and this is a community development approach, to ensure that people with lived in living experience are part of that solution, that they're doing outreach in the community. They're partnering with elders and cultural practitioners in the community to ensure that land-based services, emergency housing in a land-based environment, treatment in a land-based environment, supporting people's life in a land-based environment is part of the whole solution. No silver bullets. It definitely has taken more lives than the COVID-19 pandemic. First Nations are now starting to see an increase of COVID in their communities, in addition to addressing the struggles of supporting people who use drugs and alcohol in a variety of methods that make sense to them.
Thank you. Dr. McKenzie, I was going to ask you a different question, but please feel free to jump in on this one.
Yeah, Nico, it's the same model as before. There were problems with mental health beforehand, and Indigenous and also racialized and low-income people had significant problems with rates of mental illness and access to appropriate, effective services. COVID has exacerbated that, and we're in the middle of an echo epidemic. This echo is the echo of COVID made worse. One study recently in The Lancet showed that 20% of people get a mental health diagnosis within 3 months of their COVID diagnosis. Seems to show that 1 in 5 people with COVID end up with a mental health problem. Okay? We know it's coming. We know it's, for a lot of people, it's already here. We are going to have a significant echo epidemic, which is a mental health epidemic. We need to rethink. We need a national mental health strategy that is changed to meet our new needs. And that is an urgent thing. We need that now.
Oh, that's absolutely. And you referenced COVID. Here's another question for you on that point. How do we ensure that all populations will get equal access to all treatments, vaccines, and other COVID-related prevention and testing tools, no matter where they live or what their financial situation?
Yeah, and I think that, how do we ensure? So one of the reasons that we wanted to collect the data, and we wanted to make sure the data were available, and we wanted to make sure the data were published, is so that we can see those disparities. We can see who's getting access and who isn't getting access. If you don't have data, our individual stories, our community stories get lost. In the aggregate whole, we just get lost. So you need the data. And we need to be organized, whether we're professional groups, whether we're patient groups, whether we're community groups, we have to be organized, because we have to demand and see those data and see who's getting what. We have to do it ourselves. There are going to be loads of reasons. Oh, it's really busy. Oh, we're in the middle of a pandemic. Oh, we haven't got the time for other people to do it. People are just not going to do it. We have to get ourselves organized. And as patient groups, we have to demand those data. The reason why I say we need to change the law is because at the moment, governments or public health units can run blind and say, we just didn't know. That isn't good enough. They didn't know.
So
we should make them do something about it. If you don't advocate, if you don't push, if you don't demand, you will not get it.
Absolutely.
That at the moment, I'm really sorry. And it's not because I don't think that public health and other people are nice people. They're great people. They're very busy. But the squeaky wheel is getting the service at the moment.
Absolutely. I have a question for both of you, addressed to both of you, and it's about virtual care. So virtual care is being rolled out at an unprecedented rate. How do we combat inequities and gaps that are being widened due to this rollout, and ensure that we have an even virtual care environment where patients get the care they need when they need it. And I'm sure it's quite different in the Indigenous populations with a lot of remote and rural populations as it is from urban settings. Carol, do you want to start us off, and then we'll move to Kwam?
Yes, for sure. We know that digital capacity is greatly lacking in First Nations environments and communities. So, you know, if a school is not operating, it's not open in the community because they want to protect its citizens, and there's no internet connectivity in the community, then how do those children in that community then get access to ongoing education? And so it's a great opportunity then to focus on their culture and access to land. But that doesn't erase the responsibility of Canada. So in the Prime Minister's mandate letter to the Minister of Indigenous Services Canada, he said that digital capacity for First Nations communities has to be consistent across the country by 2030. 2030 is way too late. We need digital capacity now. So virtual care and digital capacity should be understood as a determinant of health, because that's the environment that we live in now. People get access to services, had lack of access to services pre-COVID, and the availability of services is increasing during this time through virtual care. But if you don't have digital capacity, it doesn't improve anything. And so there are efforts by the Assembly of First Nations and other national organizations to improve digital capacity for First Nations now. And again, there are good partnerships in place in some provinces to support telehealth, telemental health, and ensuring that First Nations people in remote, isolated, and rural communities can continue to receive services. I'm in one of the most southern First Nations communities in Canada. I don't have any better connectivity in southwestern Ontario than some of the northern remote and isolated communities do. And so we shouldn't make an assumption that it's a north-south issue. The digital capacity of First Nations communities has to improve to ensure that people can access services that are available through a virtual environment.
Most population health interventions increase disparities. Yeah, I mean, I totally agree with everything that Carol has said, but we need to remember most times when we innovate, we increase disparities, not close disparities. The only time when we close disparities is when the engineering of the intervention is specifically trying to decrease disparities. So if we think about it, when we are actually developing things, we can decrease disparities. In the UK, when they decided they wanted to get therapy to older people during COVID, they developed a type of therapy that was done just on a phone, not on a mobile phone necessarily, not with an app, not digitally, on a simple phone. They actually developed this module saying older people, this is for older people, so we have to develop it that way. Then they did their RCT and they showed it works, right? So they developed their intervention to make sure that it was equitably accessible to older people. And we have to think the same. We have rushed into digitalization of mental health services without doing the equity work that we need to do to make sure what we're doing decreases disparities rather than increase. And more focus on those things that decrease disparities is what we need to do, because otherwise we get into this situation where we've already widened disparities by digitalizing, and then we have a post hoc solution that says, now we're just going to decrease those disparities that we've just created. That doesn't make any sense. So we have to think a bit smarter right from the beginning. That's how we do the best job for the population of Canada.
Thank you. A little more to that point, Christine is asking if you could give us, both of you, some information about the Public Health Agency's recommendation on equity. What do you think about it? What is it? Is it going to work? Kwame, do you want to start?
Well, the Public Health Agency of Canada had just, I think in September, they released their annual report. And their annual report was about moving to pandemic equity. So they have said essentially three different things. The first thing is that the actual pandemic response, that public health response, should be done with communities in order to make sure that communities are best served, and that there are innovations to make sure that marginalized communities or communities that have been marginalized are best served. So that's the first thing. The second, it says that, well, actually, you've got to be aware that there are things you can do in the public health response, but there are existing structural issues that you have to deal with. So you do have to deal with income, you do have to deal with historical situations, you do have to deal with precarious work and housing. You have to deal with all of those things in order to really move towards equity. So there are some medium-term things. Then they say, but you need the data, And you need better governance, not only of the data, but also of the system to make sure that the system's working for people. And that means you need to decrease stigma and you need to decrease racism and discrimination. Now, their model is fine. There's one thing missing for me is they don't talk about power. And power is important because you can have the greatest model in the world, but unless you have the levers to make sure that somebody uses it, nothing happens. So I think that's the missing bit with the Public Health Agency, not talking about power. And that might be because the federal government only has so much power to make the provinces actually move in this direction. And you'll see that some provinces like BC and others will probably take up the PHAC model. And then there'll be other provinces that there's going to be much more difficulty making them take up the model. And that's why I come back, and I'm a broken record here. That's why I think the feds need to take a deep breath and they need to think about legislation. They need to think about rights. How is it legal to set up a pandemic strategy that can cause so many deaths, so many preventable deaths? How is that legal? And I think it's the same thing with regards to, as I said, health. Why is it legal? Why is it legal that we can not do the work that we should be doing to make sure that our indigenous, the indigenous populations are properly looked after?
So Carol, from an Indigenous lens, what do you think about this PHAC's recommendation on equity?
When the Constitution of Canada was repatriated, there was a lot of discussion in the constitutional talks with Indigenous people about rights. And so our right to health is explicit in treaties, but also explicit in our rights to self-determine. That doesn't mean that we can do it all by ourselves, but we do have the right. And then Canada signed on to the United Nations rights of Indigenous peoples. And in that declaration, it says that we have a right to health that reflects our culture. Again, not something that we are saying that we have to do all by ourselves, but to understand how to make public health reflect First Nations, Inuit, Métis people in Canada. It's important, first of all, to understand distinctions. So First Nations, Inuit, and Métis people all have culture, all have language. We have those things in common, but our place in Canada in legislation has been different for each of us. And so it's critically important to understand that. First Nations, Inuit, and Métis people have not had access historically to public health. Public Health Agency of Canada had no responsibility to serve us. And we didn't have public health in our communities. And so that's the history. And so where are we now? Well, we have a different relationship. It has been developing over time. And so Public Health Agency of Canada is actually funding Thunderbird Partnership Foundation for surveillance activities. And so we are collecting data, and I'll share that on Thursday when I'm talking about mental health. And speaking about the impact of drugs and alcohol, and what First Nations people are saying from the data about what will serve them best in the context of COVID-19. But in order, as Kwam said, we have to understand the power dynamics and the history that underpins those power dynamics. And so where are we at now? I think First Nations, Métis, and Inuit people are very astute. And so that's at the forefront in terms of how do we address this issue. And let's take suicide as an example. And so Public Health Agency of Canada has a suicide prevention strategy. Suicide is talked about often as the #1 issue. There's, outrageous numbers amongst Indigenous populations as compared to everyone else. And so I say, what number is enough? What's the magic number where we start making structural changes? And again, in the last Health Accord conversations, the relationship between First Nations, Inuit, Métis peoples with provinces and territories around mental health was part of the conversation, not a conversation that everyone wanted to have. And so the federal government can't force provinces and territories to serve First Nations. But why do they choose not to? Why is there a choice? Why is our health a choice? And so even when provinces and territories, and I'm being very critical here, but you asked me the question, when they are aware of the high rates of suicide, even in the context of the pandemic, why is there not a new strategy? Now, I have to say, though, there have been, those relationships have been developing. There is greater awareness. There are more strategies to address and support First Nations, Inuit and Métis, addressing suicide and promoting life. But in the context of the pandemic, again, it's exacerbated. And so we have to think about those structural changes and erase the choice, even if it's perceived choice, about responding to ensure that First Nations, Inuit, Métis people have a right to live life, have a right to the future. And so think about the communities in Canada that have been under boil water advisories for the last 25 years. 25 years. How is that possible in this country that is called Canada? That we would expect anybody to live in that environment. The boil water advisories are linked to suicide. Lack of housing linked to suicide. No access to education and healthcare linked to suicide. And so suicide is, in one sense, it's connected to a lack of vision for tomorrow. And what is curbing that vision? If somebody is in that state, depressed and hopeless about their life, they have no clean drinking water, they do not have appropriate housing, they do not have access to education and employment, how do you convince that person that they should continue living life? Well, there is an answer to that. And it's based in our knowledge and it's based in our culture. And so we have to ensure that those life promoting holistic approaches are available to First Nations, Inuit, and Métis people where they live, while we address the systemic structural issues, and while we address this perceived choice about whether or not services should be available to First Nations, Inuit, Métis people.
I don't want to ever end this conversation, but I'm going to be forced to. Kwam, I'd like to I know that I read in your biography that you used to be a writer. So I'm going to give you the last word. You're in an elevator. You've got the policymaker of your dreams. You've got 2 floors. What's the headline?
The headline. Canada is a great place to live. It needs to be a great place to live for everyone. Mm-hmm. You're a policymaker. You've been there. You want to do good. The easiest way and the best way of doing good is promoting equity and health equity.
Okay, you can write for my newspaper anytime. Carol, you wanted to add something?
I'll echo Kwam's 2-minute message or 2-floor message.
Okay, so I wanted to let you know what's going to happen now. We're going to take a short break, after which we go into breakout rooms. And the breakout rooms are only for patient groups, patients, caregivers, supporters, and of course, each of you is most welcome to join one or more of the breakout rooms. And what will be happening in those rooms is we're going to take the information as much as we can, take it all in. We're going to try to see that we've understood it, sort of in a consensus kind of way, and we're going to start to build an action plan. And by the end of day 4 of this summit, we will have an action plan for next year. And I hope you will be partners in it, help us make it happen. We can't do, as I think it was Carol, we can't do it alone. Nobody can do it alone. And so I hope you will take a look at it when it's done. And I look forward to having many, many more conversations with you about how to solve these problems. So thank you again.
Thank you.
Thanks very much, Louise. And thanks very
Good to
much.
see you today, Kwam.
Lovely to see you, Carol.
Bye-bye.
Thank you, everybody, for
Bye.
the questions.
Thank you.
So I'd just like to encourage Rena to unmute and turn your video on if you will be using video. We are honored to have Rena join us today to lead us in some mindfulness meditation for those of you who don't need to run to the bathroom, or even if you do come back, so that you can experience the joys and benefits of mindfulness. Rena, thank you so much for your assistance and support today. I look forward to practicing some mindfulness with you.
Thank you, Leah. Hello, everyone. Good afternoon. Welcome to our break. I'll take you through a short practice today. Like mentioned, my name is Rena Ruparelia. I sit on the board for the Canadian Association of Psoriasis Patients, and I'll be your guide today. So as you might know, mindfulness is about waking up to the present moment. It's a state of being where we're aware of all that's going on inside and around us without judging it or trying to push it away. When we do mindfulness practice like meditation, we set an intention to pay attention in a particular way, on purpose, and in this moment. So I'm going to invite you to get into a mindful posture that'll signal to your brain that you're doing something different. So if you're perhaps slouching, just sitting up straight but not stiff, finding a posture that allows you to feel awake, dignified. And I invite you to plant both your feet equally onto the floor, perhaps pressing down for a moment to really root in, allowing your shoulders to come up to your ears and then rolling them down, resting your hands on your lap, inviting a sense of ease into the body, and allowing the eyes to close or gaze down to limit any distractions. Keeping your eyes closed or focused at a point on the ground, let's just take a minute to breathe and to count our breaths. One inhale and exhale will count as one breath. And we're gonna do this for a minute, and I'll let you know when it's complete. So just emptying the air out of your lungs and beginning to breathe in and out. Count one, and breathing in again and out. Count two, and breathing in and out. Count three. Just continue on your own for another moment. Counting the breaths as they come in and out. And now letting go of the counting and that number. And let's take your awareness and bring it down into your feet. I want you to feel what sensations are present for you. Perhaps sensing what you can feel on the inside. Is there tingling, tightness? Maybe even scrunching up the feet, holding them tight and then letting them go and seeing what you can feel. Maybe feeling the ground underneath you, the space between your toes. Really feeling into your feet. Now I want you to just take a moment and sense into your whole body and see if there's any areas that you might have some holding or tightness, and see if you can relax them some. Perhaps you're holding your breath, allowing yourself to breathe. Maybe it's in your stomach or your chest, your shoulders, and just softening a bit. Really bringing a sense of curiosity. And before we end and before you open your eyes, I'd love for you to just take a moment to appreciate this time that you've taken for yourself, to be mindful, knowing that you are contributing to your well-being. And I invite you to even bring a smile to your face, thanking yourself once more for taking this moment. And before opening your eyes, let's take 3 deep breaths together. So just emptying the air out of your lungs. Now let's do a deep inhale through the nose and exhale through the mouth with a sigh. Allow your breath to come in again and exhale out the mouth. And one more time, breathing in and exhale out the mouth. It's wonderful. So before you open your eyes, just wiggling fingers and toes, maybe moving your head a little, your body back and forth, and then gaze up to the screen when you're ready. Thank you so much for this time. I will be back on December 8th. I hope that you will bring some mindful moments into the rest of your day. And thank you for having me. I'm Marina Ruparelia. Thanks. Thank you.